Hello all, after understanding the mechanism of acute inflammation, the events that take place at the vascular and the cellular level in our body, and how the soldiers of our body are recruited to fight the enemies, that is, the foreign bodies and microbes, let us now dive in deeper and try to understand the mediators who mediate the inflammation in our body. As always, comments, doubts, and healthy discussions are most welcome in our comment box because knowledge shared is wisdom gained. So let's go. So before we move on to how mediators exactly function in our body, let us try to understand what is the definition of mediators. Mediators are usually substances that initiate and regulate the inflammatory reaction. That is, they are like chief army officers who ensure that the war within our body, which is inflammation, takes place successfully and our body is safe from the foreign body or the microbe. Mediators are divided into further classes. One is a cell derived mediators and the second is plasma protein derived mediators. So, cell derived mediators have histamine and serotonin, which are also called as preformed mediators since they are already formed even before inflammation takes place. The second class is cytokines, prostaglandins and leukotrienes, which are also mediators which are synthesized de novo in our body. The second is plasma protein derived mediators, of which there are many mediators, but the most important is complements. Now these are usually synthesized within our liver. Let's now dive deeper into the mediators of inflammation. The entire list that you see here are the principal mediators of inflammation. We will start one by one. So first we will discuss about the preformed mediators of inflammation, which is histamine and serotonin. Histamine is a vasoactive amine which is usually found in the mast cells, basophils and platelets. The primary action of histamine is vasodilation, increased vascular permeability and endothelial activation. The second vasoactive amine that we have discussed before is serotonin. Serotonin is also a preformed mediator and it is a vasoconstrictor. We will now discuss how the arachidonic acid metabolites, which is prostaglandins and leukotrienes, are synthesized and what are their functions in inflammation. So as you can see here, we have the cell membrane phospholipids which with the help of phospholipases generate arachidonic acid metabolites. Arachidonic acid metabolites generate prostaglandins and leukotrienes. Does this flowchart seem a little bit too detailed? Let's simplify this in the further slides. Let's now explore the first main metabolite synthesized from arachidonic acid, which is prostaglandins. Prostaglandins are synthesized from two major cyclooxygenases. One is COX-1, which is primarily involved in the homeostatic reactions of the body, and the other is COX-2, which is primarily involved in inflammation. As you can see here, most of the prostaglandins have the abbreviation of PG with the suffix of G2, H2, I2, D2 or E2 depending on what function they are known for in the body. PgI2 is synthesized from cyclooxygenase with the help of PgG2 and PgH2. PgI2 primarily is involved in vasodilation and it inhibits platelet aggregation. From PgI2 is synthesized thromboxane A2. Thromboxane A2 is a vasoconstrictor which is entirely opposite of PgI2 and it promotes platelet aggregation. From TXA2 we have PgD2 and PgE2 which is involved in vasodilation and it is involved in chemotaxis of the foreign bodies or the microbes. In addition, prostaglandins are also responsible for pain and inflammation in the body. Now these prostaglandins are inhibited by COX-1 and COX-2 inhibitors and aspirin and indomethacin as you can see here. We will now look at the second metabolite of the arachidonic acid which is called as leukotrienes. Leukotrienes are synthesized from lipooxygenases. They are primarily involved in vascular and smooth muscle reactions and they are also involved in leukocyte recruitment. Now, the same rule for prostaglandins applies to leukotrienes also. They are abbreviated into LT with the suffix of A4 B4, C4, D4 or E4. Now lipooxygenases are several in the body, but the most important lipooxygenase is 5-lipoxygenase, which is predominantly found in the neutrophils. It converts the 5-HPETE into 5-HETE, and this reaction is important because this is the precursor for the leukotrienes. So from 5-HPETE we get LTA4, which is then converted into LTB4. LTB4 is a very important chemotactic factor for neutrophils. From LTA4 there is generation of LTC4, D4 and E4. Together they are very intense vasoconstrictors and they also cause bronchospasm. Now, these LTC4, E4 and D4 are inhibited by certain lipooxygenase inhibitors. This 5-HPETE will then get converted into LXA4 and LXB4 with the help of 12-lipoxygenase. We have now seen how the arachidonic acid metabolites, which is prostaglandins and leukotrienes, and histamine and serotonin mediate inflammation. Now let us look at the role of cytokines and chemokines in mediating inflammation. Since we have discussed the role of cytokines and chemokines in detail in the previous video, I will keep it very brief. Cytokines are mediators which are produced by various cells like macrophages, dendritic cells, endothelial and epithelial cells. The most important cytokines, as we know, are TNF and IL-1. What do? They help in leukocyte recruitment by promoting the adhesion of leukocytes to the endothelium and migration to blood vessel. TNF and IL-1, as you can see here, contribute to local inflammation and systemic inflammation. So, what is the major role of TNF and IL-1? They will help in endothelial activation. How do they do that? They increase the expression of the endothelial adhesion molecules. As we already know, they are I and P-selectin and the ligands for the leukocyte integrants. They also activate the leukocytes, as you can see here. They augment the response of the neutrophil to the particular bacterial endotoxin. In terms of systemic effects, they mainly produce something called as the systemic acute phase response. TNF, for these reasons, are also useful in the treatment of chronic inflammatory diseases like rheumatoid arthritis and psoriasis. Chemokines are a family of 8 to 10 kilodalton proteins, and as you already know in the previous video, they act as chemoattractants for specific type of leukocytes. We will see in brief what are the different chemokines. So the first is CXC chemokine. What is X here? X is the amino acid residue which separates the two chemokines. So a classic example of this kind of chemokine is the IL-8. IL-8 is secreted by macrophages and endothelial cells, which usually cause chemotaxis of the neutrophils. The next is CC chemokine, wherein you have two chemokines which are adjacent to each other. There is no amino acid residue separating it. The classic example of this is MCP1, CCL2 and eotaxin. They usually attract monocytes, basophils, eosinophils and lymphocytes. The next is the C chemokine. C chemokine is very specific for lymphocytes. The next is CX3C chemokine. Here this exists in two forms. One is the cells which are surface bound and the next which are soluble bound. The classic example of this kind of chemokine is a fractalkine. Now that we've seen how the cell-derived mediators mediate inflammation, let us explore the world of the plasma protein-derived mediators. The most significant plasma protein-derived mediators are the complements. Complements are a group of plasma proteins that usually act as host defense against microbes and they help in pathological inflammation. Complement proteins usually exist in inactive forms which are activated by a proteolytic enzyme that degrade the other complement proteins which trigger an enzymatic cascade that amplifies inflammation. Are you confused? Let me explain this further. So what I just told can be explained by the proteolysis of C3. Proteolysis of C3 occurs in three forms. One is a classic pathway, the next is the alternate pathway, and the third is the lectin pathway. So C3b forms because of the action of C3 convertase, which converts C1 to C3. How does C1 get activated? By three methods, like I said before. Now in classical pathway, the classical pathway is triggered by binding of the C1 to the antibody. The alternate pathway usually occurs when there is no antibody. So what will happen? It will usually, the C1 will bind to some sort of a LPS or an endotoxin or a cobra venom. The lectin pathway usually occurs when a plasma mannose binding lectin along with carbohydrates activate your C1. So what will happen? There is an enzyme called as the C3 convertase. Now this C3 convertase converts your C1 to C3A and C3B. C3A is usually released and the C3B is usually covalently attached. This C3B will add more C3B to itself and then it will release two molecules, two complements. One is C5A and the other is C5B. Now this C5A and C5B are activated with the help of C5 convertase enzyme. So as you can see here, with the help of C5 convertase enzyme, the C5A and C5B are activated. Like I told you, the C5A will be released, the C5B will attach itself to the cell surface. It will trigger the C6 and C9, which will lead to formation of the membrane attack complex. Complements have three main functions. The first, as you can see here, is inflammation. How does inflammation occur? So you have the C5A and the C3A, which have increased vascular permeability and they cause vasodilation. They are also a chemotatic agent for neutrophils, eosinophils and basophils, and the C5A will trigger the lipooxygenase pathway. C3b will cause the phagocytosis of the microbe, and as you can see here, because of C6 to C9 there is formation of the membrane attack complex, which will cause the lysis of the particular microbe. Now that we've seen how complements mediate inflammation, let us look at some of the regulatory proteins which regulate the function of complements. Regulatory proteins are important in various processes of our body, but especially inflammation, because they'll avoid a continuous inflammatory response in the body. Because as we all know, waging a war indefinitely only leads to more casualties. Some of the regulatory proteins are, the first is C1INH. C1INH, as the name suggests, inhibits the C1 complement and its deficiency leads to hereditary angioedema. The next two are DAF and CD59. DAF, the full form is decay activating factor, and CD59 inhibits the membrane attack complex. This is attached to the cell surface with the help of a GPI anchor. So what will happen is, if the GPI anchor is deficient, there will be increased complement activation, which will lead to RBC lysis and it will lead to a condition called as PNH. The full form of PNH is paroxysmal nocturnal hemoglobinuria. The third is complement factor H. Complement factor H inhibits the alternate pathway. So what it does is, it will inhibit the C3b and the C3 convertase. So its deficiency leads to an atypical form of HUS. Now let us look at some of the other mediators of inflammation. We will start with kinins. Kinins are plasma protein derived mediators which are generated from high molecular weight kininogen with the help of kallikrein. The most important kinin is bradykinin. Bradykinin has its actions similar to histamine. So there is increased vascular permeability, smooth muscle contraction, vasodilation, and it causes pain. Bradykinin or kinins are usually inhibited by kininases. The second is the platelet activating factor. Now platelet activating factor, it causes platelet aggregation. But it also, apart from that, causes multiple inflammatory effects like vasoconstriction, bronchoconstriction, vasodilation, and increased vascular permeability. The third is the products of coagulation. Products of coagulation causes platelet activation during clotting, and it also causes fibrin production, which stimulates inflammation. The last are neuropeptides. The two most important neuropeptides are substance P and neurokinin A. Substance P usually causes transmission of the pain signals and increase vascular permeability.